Hello everyone and welcome to Boundless Dentistry. In this video, we'll talk about management of class 2 malocclusion. Class 2 malocclusion is very commonly encountered in the population. It basically means that the maxilla is positioned ahead of mandible, and that leads to aesthetic as well as functional disturbances. So that's why patient seeks treatment for such anomaly. So in this video, we'll talk about everything that is related to management of class 2 malocclusion. So let's get started. Now let's begin with defining what actually is class 2 malocclusion. Simply put, class 2 malocclusion is basically when the maxilla is positioned ahead of mandible. Now what do we mean by that? As you can see in this diagrammatic representation, class 1 is the normal relation that is to be present for functional reasons as well as aesthetic reasons. Now you can see maxilla is positioned just ahead of mandible. That is the normal relation, class 1 relation, which is normal. But in class 2 cases, the maxilla is positioned way ahead of the mandible. Now, maxilla is prognathic, positioned forward. Mandible is either positioned backwards, that is called as retrognathic, or it can be normal as well. But maxilla is prognathic. So, maxilla in class 2 malocclusion is prognathic, and mandible can either be retrognathic or normal. So, that is class 2 malocclusion simply put. Now let's discuss further about class 2 malocclusion, focusing on maxillary incisors. In class 2 malocclusion, they are mostly proclined. This is the normal relation. You can see their position normally straight, but when they are proclined, their crown is in forward direction. As you can see here, the crown is in a forward direction. That is, maxillary incisors are proclined. Now, when we talk about treatment options that are available for class 2 malocclusion, it can be easily treated in growing years because we can stop or modify the growth of mandible and maxilla, and it can be easily treated. Treatment options are a bit difficult in adult patients because the growth has now stopped. So we go for either camouflage and surgical options that we'll discuss at the end of this video. Now, when we talk about the molar relation in class 2 malocclusion, there is class 2 molar relation. The normal class 1 molar relation is when the mesiobuccal cusp is occluding in the buccal groove of lower 6. But in class 2 molar relation, the distobuccal cusp is now occluding in the buccal groove because the maxilla has been placed forward. So these teeth also move in forward direction. So now the distobuccal cusp is occluding in the buccal groove, as you can see in this picture as well. You can see this distobuccal cusp is occluding in the buccal groove. So this is known as class 2 molar relation. Now there are certain clinical features that we encounter in patients having class 2 malocclusion. Now class 2 malocclusion is divided into two parts. We have class 2 division 1 and class 2 division 2. Firstly, we'll begin with talking about class 2 division 1. Now, in this case, there is class 2 molar relation. As you can see here, the distobuccal cusp is occluding in the buccal groove. So this is class 2 molar relation. Now when we talk about the facial profile, as we can see from the side views, it is convex. As you can see, this is the convex view. So this is the characteristic facial profile of class 2 malocclusion. Next, you can also appreciate that in class 2 division 1, all of the incisors are proclined, the central incisor as well as the lateral incisors. Now further, you can also appreciate that there is increased overjet, the horizontal distance between the upper and lower incisors, because these incisors are proclined. So there is increase in overjet, and then it also leads to increase in curve of Spee as well. Now since these incisors are proclined, there is shortened upper lip. And next, because there is increased overjet, there is space present between the upper and lower incisors. Now, in most of the cases, between these space, the lower lip comes. So this leads to a phenomena known as lip trap, because the lower incisor has been trapped between the upper and lower incisors. And some cases we can also see hypertonic mentalis muscle, which is this muscle, and in few cases the lower incisors can also be proclined. So these are the clinical features that we encounter in patients with class 2 division 1 malocclusion. Previously we mostly focused on dental features of class 2 malocclusion, but these anomalies can also be present on the skeletal level as well. Now, we've discussed this before, but let's talk about it again. That is, the maxilla is present ahead of mandible, that is prognathic maxilla, which is known as maxillary protrusion. Maxilla present ahead of the mandible. Now, mandible is positioned either in normal or behind its normal position, and that is known as mandibular retrusion. Either we can have maxillary protrusion, maxilla can be normal, or we can have mandibular retrusion or mandible can be normal. So when we have anomalies present in maxilla and mandible, this is known as combined cases where there is problem in maxilla as well as in mandible as well. It depends on patient to patient. Now, let's talk about the different etiological factors that are present which can lead to patient developing class 2 malocclusion. We have three categories. First is the prenatal, natal, and postnatal causes. Let's begin with talking about prenatal causes. It can be present in family as well. For example, mother, great father, grandfather, and so on. They can have class 2 malocclusion. So the children they are being born, they have a tendency to have class 2 malocclusion. There are certain drugs which can lead to development of class 2 malocclusion. They are known as teratogens. And for example, in some cases where the mother is undergoing some irradiation for example, some cancer, that can also lead to disturbance in development of maxilla or mandible, which can predispose to class 2 malocclusion. Now, in natal causes, we have, for example, during delivery, there is some kind of trauma because sometimes forceps are being used. So when the forceps are being used, there can be some damage, especially to the mandibular condyle. So that can interrupt the development of mandible. That can lead to class 2 malocclusion. See, the damage to the TMJ. The postnatal causes, we have trauma to mandible or TMJ that can disrupt the growth of the mandible. Also, in some cases, for example, in childhood cancers, the patients are given radiation, so that can also affect the growth of maxilla and mandible. In juvenile rheumatoid arthritis, there is disturbance in the condyle, so that can also lead to class 2 malocclusion. Lastly, mouth breathing, infant, thumb sucking, these can also lead to development of class 2 malocclusion. So these are the most common prenatal, natal, and postnatal causes that might predispose or lead to development of class 2 malocclusion. Now, in some cases, the skeletal features are normal. For example, in this radiograph, you can see the maxilla and mandible, they are present in their normal relation. You can see the maxilla is present just ahead of mandible. That is the normal skeletal class 1. But in some patients, the maxilla and the mandible, they can be normal, but there is some problem with the dental characteristics. So that can lead to dental class 2 malocclusion where the skeleton is normal. You can see in this lateral ceph as well, the maxilla is normal and the mandible is normal as well. But there is something wrong with the teeth. The thing is that the incisors are proclined, which can lead to increased overjet. Because there is proclination, increased overjet, sometimes there's spacing present as well. As you can see in this diagram as well, you can see some spaces are present between the maxillary teeth. If you look at cephalometrics, you will find that the SNA, that is to measure the maxilla, either is protruded or retruded, you measure it through here, so it will be normal. Same goes for SNB, which is to check mandible, that will be normal. And when you check A and B, which give you either the patient as class 1, 2 or 3, that will come as class 1. That means that the maxilla and mandible both are normal. Something is wrong with the teeth. As we've discussed before, there will be class 2 molar relation. The distobuccal cusp is occluding in the buccal groove of lower 6. Sometimes there is some discrepancy associated with these teeth as well. They can be in most of the cases smaller, and that leads to generalized spacing, as you can see in this diagram as well. And in some other cases as well, since there is problems associated with the teeth as well as sometimes there can be impactions as well. Most commonly maxillary, canine and second premolar are impacted. So these are the features that are associated with skeletal being normal but dental abnormalities which lead to class 2 malocclusion. Now, we have diagnosed that the patient is suffering from either skeletal or dental or both class 2 malocclusion. We have diagnosed it, we have confirmed it using cephalometrics clinically and doing other investigations as well. Now we have reached to the point where we have determined that the patient has class 2 malocclusion. Now, we move on towards the treatment. Now, there are certain treatment objectives that we keep in mind when we are treating a patient. Firstly, we have to reduce the overjet as we have discussed before, which leads to lip trap and also increased chances of trauma and avulsion of these teeth which are proclined. So we have to reduce the overjet. Sometimes there is also increased overbite, deep bite. So we have to also correct that because in most of the cases it leads to gingival trauma. Crowding and irregularities are also present as we have discussed before. Some teeth are impacted, maxillary canine or second premolar. They are also impacted, so their presence leads to crowding and irregularities, so we have to correct that as well. Molar relationship that we have discussed is class 2, so we have to correct that as well. Sometimes because the maxilla is constricted, crossbites can also develop. So when that is present, we have to also correct that, mostly for functional purposes because aesthetically they are not visible as compared to the anterior teeth. And since there is abnormalities around the teeth that is present, the muscles are also disturbed. As we have discussed before, there is hypertonic mentalis muscle. So all of these treatment options also lead to correction of the musculature as well. Now, let's talk about the treatment of class 2 skeletal malocclusion. We have three approaches. It's mostly dependent on the age of the patient. We can modify the growth that is helpful in growing patients. In, for example, patient in their 10, 11, 12 years of age, this growth modification is really helpful and it's the most beneficial treatment for the patient. Now, when the patient has reached its adulthood, then growth has stopped, so we cannot modify the growth of maxilla or mandible, so we go for either camouflage treatment, and if even camouflage is not done properly and it's of no use to the patient, then we finally opt for surgery. Now let's begin by talking about growth modification. Now in growth modification there is maxillary prognathism, and when mandibular deficiency is present it can be interrupted when we use some functional and orthopedic appliances. Now, this treatment is started when the patient is in mixed or early permanent dentition phase. Now we have to start this treatment before growth has stopped, because if the growth has stopped, this growth modification treatment is of no use. You can see in this picture, this is a functional appliance. Now it is used to move this mandible ahead so that the mandibular deficiency can be corrected. Now when maxillary prognathism is present, that is when the maxilla is positioned ahead of mandible, we have to correct that. Now to correct that, the most common appliance, the orthopedic appliance that is used, is called as headgear. Now you can see in this picture as well, we have three kinds of headgear that are present. Now when the headgear's strap is present around the neck, that is known as cervical headgear. When the strap is present around occipital region, that is known as occipital headgear or hypal headgear. Now, in some cases, both of these straps positions are used, and that is known as combination headgear. Now, both of these headgears have their particular indications. But the basic function of a headgear is to prevent the anterior and inferior movement of the maxilla. You can see initially the maxilla and mandible are then present here. Maxilla tends to move anteriorly as well as inferiorly. So headgears use these phenomena to correct the movement of the maxilla in this direction in order to prevent class 2 malocclusions development. Now, cervical headgear, you can see over here, is used for posterior and inferior force, and it's most commonly used in horizontally growing patients, because if it's used in vertically growing patients, it leads to vertical growth of the maxilla. Similarly, the occipital headgear is used in that cases where the patient is growing in vertical direction and we have to prevent that, and a posterior and superior force is used to restrict the growth of maxilla. And in some cases, combination headgear, cervical and occipital parts can also be used. So this is all about headgear, how they restrict the maxillary growth. Now, in some cases, there is mandibular deficiency also present. Now, mandibular deficiency, when it is present, it can be corrected with functional appliances. For example, we can use activator and bionator. They basically move the mandible in forward direction in order to correct its deficiency. In some cases, where the patients are at the end of their growth phase, we can also use some other advanced and more rigid appliances that are Jasper jumper and Herbst appliance as well. As you can see, this is the Herbst appliance. This is the steel band, tube, rod and screw, and it moves the mandible in anterior direction to correct its deficiency. So we've talked about how we can influence maxillary prognathism and mandibular deficiency in growth modification phases. Now let's talk about the second treatment option, that is camouflage. Now camouflage is most commonly used when there is mild to moderate disturbance that are present, because if the disturbance is really severe, for example the mandibular is really retrognathic, so in that cases and when the growth is also ended, you cannot correct it by using camouflage, then we have to go for surgical treatment. So camouflage is most commonly used when there is mild to moderate disturbance. Now we use camouflage treatment when the growth phase has ended. Now camouflage treatment is basically based on the phenomena that is extraction of teeth, so that you can adjust the teeth and correct it somehow so that it's more aesthetically and functionally pleasing to the patient as well. Skeletal changes cannot be done because there is growth has also ended and we are not going for any surgery, so only dental changes we can do over here. Now the main objective of camouflage treatment is to reduce the overjet, also overbite, correct minor irregularities, along with correction of incisor and molar relation as well. Now, most commonly we extract the first premolars, and if the arch is really well aligned, for example the lower arch, only first premolar is extracted. Now in some cases crowding may be present in the lower arch as well. So when that's the case, we extract the maxillary and mandibular first premolar as well. Now, in some cases, anchorage is also required. So in that cases, we can also extract second premolar as well. So this is all about camouflage treatment in patients where growth has been cessated and patient has mild to moderate disturbances. So in that cases, we can do camouflage treatment in order to achieve a better functional and aesthetic results for the patients. Now, when the growth has also ended and the patient has severe class 2 malocclusion, then we go for surgical treatment, that is orthognathic surgery. Now, we have two options. Either we can do maxillary setback, that is to move the maxilla in backward direction, or we can do mandibular advancement, that is move the mandible in an advanced direction, in this direction. Now, to move the maxilla backwards, we can go for Lefort 1 surgery as well to move the maxilla in backward direction. To move the mandible in forward direction, we go for bilateral split sagittal osteotomy (BSSO), that creates two cuts in the mandibular posterior region and moves the mandible in forward direction. So we can either move the maxilla backward, that is called as maxillary setback, or we can go for mandibular advancement, that is moving the mandible in the forward direction. Both of these treatment options, either of them can be done to correct severe class 2 malocclusion in patient where growth has been stopped. Now in certain cases we can also go for class 2 elastics. Now in this picture you can see the class 2 elastics are used where it stretches from the maxillary canine till the lower first molar. Now inter-arch force is provided which moves the maxilla in backward direction and the mandible in forward direction. So this can also be used. Now only dental changes can be appreciated over here. There is no significant skeletal changes present over here. But one major drawback associated with long-term use of class 2 elastics is that it can lead to extrusion of these teeth where anchorage is present. Extrusion of them can be done. So this has to be kept in mind when we are using class 2 elastics. Now the indications for using class 2 elastic is when there is permanent dentation, bonded and banded appliances are used, and after initial leveling and alignment of the arches has been done. So in that phase, then we can use class 2 elastics. Now, as we've discussed before, in some class 2 cases, there can be deep bite and cross bite. Now, to correct open bite, as you can see, there is some space over here. We can use anterior bite plane. Here in this picture, you can see anterior bite plane is used. Now, when anterior bite plane is used, this leads to, since there is lack of contact, as you can see in this green shaded area, there is lack of contact. So this leads to extrusion of these teeth in order to maintain contact. So in that cases, this open bite can be corrected. Next, in some patients, crossbite can also develop. As you can see, the maxillary teeth are present lingually as compared to these mandibular teeth. So this is mostly associated with in maxillary arch where they are constricted. So we have to expand this. So in order to expand this to achieve a normal relation in these teeth, we use springs and screws in order to expand these teeth so that these teeth can be present buccally as compared to the mandibular teeth. This is to correct the crossbite. Now, previously we talked about class 2 division 1, entire thing about that. Now we turn our focus towards class 2 division 2. Now in this case, there is some differences as compared to division 1. In this case, there is retroclined central incisor upper and proclined lateral incisor. As you can see, the central incisors, they are retroclined, positioned backwards, and the lateral incisors are present in forward direction. They are proclined. So this is the basis of class 2 division 2. Some other features you can also appreciate. For example, there is class 2 molar relation, as you can see here. This is distobuccal cusp is near the buccal groove. Central incisors can also are proclined here, uh, or they can be retroclined as well. The lateral incisor can be proclined or retroclined, but in most cases they are proclined and the central incisors are retroclined. In some cases, all of these four incisors can be retroclined as well. In this case, you can also appreciate there is increased overbite. In most cases, patient has straight profile as compared to division 1 where the patient had convex facial profile and the face is broad and sometimes there is deep mentolabial sulcus as well. Now lastly, talking about the treatment option that is available for treating class 2 division 2, we have to correct the incisal relation, crowding, minor irregularities and relief of gingival trauma. Mostly these last two things are associated with deep bite. So we use anterior bite plane, as you can see over here. We use this bite plane here and as we've discussed before, the maxillary teeth extrude. This leads to correction of deep bite. Sometimes you can use functional appliance as well, so for example activator and bionator, in order to correct all of these anomalies. So in this video we talked about everything that is related to management of class 2 malocclusion. Initially we talked about what actually is class 2 malocclusion, its skeletal and dental features. Then we talked about class 2 division 1 and class 2 division 2, their clinical features, investigation, diagnosis, and how finally we can treat such cases. So I hope this video was useful for you, and if you like this video, please like, share, subscribe and press the bell icon. Thank you for watching this video. See you next time.